that, we can get started with questions. Yeah, right here.
Hello. So it sounds like you guys have integrated IPM as part of the asthma management. My question is there data showing specifically that the pesticides are contributing to symptom severity or symptom frequency and or the development of asthma in kids who don't have it?
It's a great question. And do I need to repeat it for people online, or?
No, because she had the mic. So.
You had the mic. Okay, great. So there's a lot of great questions in that one question. So one is whether or not pesticides contribute, and the other is, what should the components of integrative pest management be? And I think the second one's easier, to handle in terms of, whether you think about a pesticide-free approach to it or not. I think the better programs include bait and then elimination of pests that way, and that even within the use of baits, that there are better and worse approaches. I think I'll just give you an example. That the NIEHS conducted a study looking at cockroaches, and they compared an entomologist, so a bug expert-driven approach, to hiring the companies that are pest management companies. And what they found was that there was actually a very good logical approach, which was to put these baits along the places where entomologists see the trails. So they look for the trails for the cockroaches, and then monitor what happens. So put in new baits after they've been eliminated to see if they've come back, and use the monitoring program to then decide when you need to sort of redo your program. The professional companies so far, what they tend to do is spray in spots that just happen to be maybe typical, like corners or holes or things of that sort, but not literally driven by where the critters are seen. And then they also come back on a schedule, but a time schedule not based on what the results are. So they might come back in 6 months or a year or something. So even within that, there's a good approach. I think the ones that don't spray insecticides are better because of the concern that you bring up, which is whether or not they can provoke asthma. And virtually any spray of any sort, whether it's an insecticide or a cleaner or something else, can provoke an asthma attack in an asthmatic. So I think the ones that don't involve sprays are the better approach.
And just to add on to that, when we started, I had to actually sell the community health workers on integrative pest management. They were more in tune with using the raid sprays. One even had told me about using antifreeze on a cotton ball, and that would kill mice. So when we started, I was like, all right, that's one way to do it. But when we're working with our families, we're going to use IPM. All right? And they followed along with me. They're like, okay, Kate, yes, we're going to do it. But it wasn't until they actually implemented it in the home setting where they saw the improvements, especially with the roaches, and they would come back 2 weeks later and it would be a significant change, that they were sold on it. And so they became really good advocates for this type of an intervention, which also helped with buy-in for the family too, because they saw an immediate improvement.
I have a question. When there is in the natural history of asthma is towards an improvement as the kid gets older, how can we tell that the improvements or quantify the magnitude of the benefit of this intervention? That is, how can we say that it's because of the intervention versus it's, the kid is improving? And, do we have any case control study, or because the before and after probably, it's a little bit more difficult to make those assumptions in.
Well, I know you can answer it really well.
Well, yeah, it's a great question, right? I mean, it's an issue of study design and what standard of evidence you need in order to guide what you're going to do. And I think that part of the reason that we presented together is that I was presenting more clinical trials evidence that had a control group. And the good thing about clinical trials is that by having a control group is you can be confident that the signal you see is from the intervention. The bad thing is that we highly select the people to get the intervention, and it also doesn't prove that you can just roll it out in the community. So I think the two kinds of research are complementary. I think you have to do NIH style controlled trials to prove that an intervention can work. But that's not really feasible on a mass scale, and to ask a city, or a state or a country, to roll it out in a controlled way is difficult. So I think, some of it's program evaluation after having proven that an intervention can work in certain circumstances. I mean, your point's a great one.
Following up on that, but I think also when she's doing the Medicaid analysis, when you're actually getting the real cost data, at that point she could go ahead and find match controls in the community. That's one thing we've done.
And that's exactly what we plan on doing. Yeah, that we'll have a match control group. Yes.
Yeah, right down here.
Kate, you mentioned that now that you have data from Baltimore as well as Seattle, what are your thoughts in terms of moving these studies into a research to practice mode?
So I'm more than ready to move this into practice, and I can see it in a variety of settings. So I can see it in the health department, and there's positives to that. I can also see it based out of a patient-centered medical home, so where a child is already being seen. And there's a possibility that you might actually see a greater improvement in asthma management when they're locked into a medical home, possibly. But I could see it in both settings. And I think that with the Affordable Care Act, if it moves forward like we hope it does, that you'll see more of these preventative services in place, as I hope.
I just want to follow up too, if I could, because I think that's it's a great point, which is the what to do next. And I think part of it's a matter of people who care about the issue to try to articulate some of the cost and benefit issues of the programs as well. The slide that I showed that was done by the NICUS study, where there was a 1-year follow-up period showing that it still worked even after the intervention was gone, is enormously important because we accept, without even thinking that hard, that it's okay to use asthma medications that have a temporary effect. And we pay hundreds of dollars per month for each medication, and that's a no-brainer. We just do it. But then when we talk about a program that might average over a year, $100 a month, people get excited. They say, well, that's an expensive thing. How are you going to sustain it? And so I think, making some case that, costs are worth it in some cases. The other is that, medications, for example, have side effects. Most, but not all, of the interventions that target the environment don't really have side effects. Getting somebody to quit smoking, doesn't cause health problems for the most part for the child, if the parent's smoking around them. Air cleaners use a little bit of electricity, but they don't harm you. And so there's other ways to think about the trade-offs too, in terms of, costs and benefits that I think we all collectively have to articulate to the people who are in charge of allocating, dollars for healthcare.
Okay.
I had a couple of questions. One, the data on your smoking counselor were not significant in terms of the effectiveness of that, and I'm wondering if there are alternatives that you might recommend, for programs that might be implemented in other cities. And then the second question, your interventions were focused on children who had severe asthma, moderate to severe asthma. And yet the guidelines recommend that these kinds of interventions be considered for all asthmatic children. So I'm wondering if you have plans to expand the intervention for all asthmatic children.
So the second part first maybe, so about, where you should go with it. I think that, the guidelines are a little soft in terms of the recommendations about who should get the interventions. And I highlighted in a couple cases where they'll say if possible, for example. It doesn't designate a severity level, but it's kind of a soft prompt as opposed to saying that all asthmatics of all types should get these interventions. There's a feasibility part that's implied there. In terms of even allergen reduction, the guidelines say that for people whose asthma is at least at the persistent level, that they should have allergy testing done through either blood or skin tests. And so there's a little hesitation, I feel, in the guidelines in terms of who should get it. From a trial standpoint, there's an issue of always of who do you select for a trial, and I think the people who are sicker to begin with have a better chance of showing a signal, and so that's the place to start in some cases, and then see if you can replicate that same magnitude of benefit in somebody who's not as sick to begin with. Where the study that I showed of Peyton's, Peyton Eggleston's was the first of those air cleaner studies, not the one that had the health coach, and his actually was at the mild range. So his were not very symptomatic to begin with. The second one was a little sicker, and that was deliberate in order to try to be able to find a signal. As far as the health coach goes, we're talking about cigarette smoking, so there's a massive literature on what it takes to get people to quit smoking. And it's partially successful, right? There's evidence for counseling working, there's evidence for pharmacology working, and the two together working even better yet. This particular model was built around the notion that if you could have a smoke-free home and enforce that, what would that look like? And this was one more trial where I think, we found that smoking behavior is very stubborn, and that it's very hard to get people to change their smoking behavior. So I honestly don't know what to do. I mean, it's not enough just to tell somebody that you might be harming your child. It's not enough to tell them to smoke outside, because we know that the smoke comes back in if somebody's on the porch, for example. So it's very hard. I don't know the answer. This particular trial only showed that that an air cleaner could contribute, although not be a complete solution.
Okay, well, we do have some questions from our audience online, so I want to take a minute to take some of those questions right now. And this first one comes from Tiffany, who works in a Head Start program. She says, I work with families of preschool-aged children, and asthma is an increasing problem for our families and young children. What would be your recommendations for how I can use this information learned in this training to help our families?
So, at least in Baltimore, we've spent some time actually trying to reach out to Head Starts, so that we do it in two ways. We offer education at the actual site. So we'll work with the workers, people that actually work at Head Starts, and we'll provide education to parents, so we can do group education classes to share insight. We also have a smaller asthma home visiting program that has that's not a study, but it's mirrored after RAT, and it's smaller. It's 3 home visits. Community health worker model with nursing supervision, and that actually does see children age 2 to 18, and so that Head Start kids are actually can enroll.
Okay. This other question it's really 2 questions. We're now in the 2nd generation of children since these home efforts began. And have you considered addressing the prevention of asthma and allergies through breastfeeding or provided by breastfeeding? And then also, part 2 is, does inconsistent medical care affect asthma management? Why does the Maryland Breathmobile see patients who are already seeing a consistent medical provider at Johns Hopkins?
Well, those are very different questions. So the first one about asthma prevention is a very important topic, and one a lot of us who work in asthma think hard about. And there have been NIH and other federal agencies that have convened groups of people to try to figure out where or if there is low-hanging fruit in terms of prevention. There really isn't a leading major single target, for reduction of incident asthma. And there are different attempts that are going on. For example, there's a study looking at vitamin D supplementation in pregnant moms to see if the children who are born will be less likely to wheeze and then eventually be diagnosed with asthma. That's one approach. There's people who are thinking about the microbiome and whether or not the gut bacteria of children, if it's manipulated on purpose by a supplement of some sort, or through other strategies like preferring vaginal over C-section birth, where the flora that the child gets are different in that case. There's a lot of different potential strategies, but at the moment there isn't a single way to prevent it, and there's not a single best candidate, I don't think, for prevention. Breastfeeding, is a big issue. There are observational studies that seem to show an advantage, and some that don't, I think, in terms of at least asthma health or allergy. I think the evidence is tilted definitely in favor of there being a protective effect. Trials, I don't work in that particular realm, so I don't know, but trials seem a little daunting to me. I mean, thinking about the idea of assigning someone to breastfeed or not would be difficult. But I don't do that sort of work. Maybe somebody's got a good idea how to do it. But a lot of this gets driven by randomized controlled trial evidence on what to do, not just what might make sense or what an observation might have shown. Do you familiar with the breathmobile? Is it
And I can. So one thing is that what we did find is that coordination of care was extremely important when managing children with asthma. And so there were times when you saw that a child was seeing a specialist and also a primary care. I'm not sure exactly the question that the person presents online, because the breathmobile, when I think of them, it is a specialty clinic for children. It's a clinic on wheels. It's mostly stationed at schools throughout the school year, and that's staffed by NP pulmonologists or NPs with background in pulmonology. So depending on who they see at Hopkins, they could be seeing just a general, pediatric doctor, or they could be seeing a specialist. But the point of the RAD Home visiting program is that when we worked with the families and we tried to really find out, okay, who else does your child see for medical care? And so when that encounter form was faxed to providers, it actually has all the physicians on the cover sheet. So it's going to have breathmobile, it's going to have Mercy Medical. If the kid is seeing 2 different people, if they're seeing a GI specialist, it also goes to them. So we're trying to kind of break through that barrier and coordinate care.
Here's another one. What does the state Medicaid program think about funding the program in the future?
So we had the opportunity to do a small presentation to the state a couple months ago. They were really interested in our program results and suggested that we move forward with the economic evaluation of the RAD Medicaid claims data, while at the same time moving forward on they have something called an innovation website, and so that they'll feature programs that are up and running, and so that you can disseminate information to others. Because the whole point of, there's many points to RAD. One of them is to improve children's health, but it's also to share what we've learned with others. So we want to be able to do that. And with that, we hope it will open more doors to actually work with managed care organizations who have a vested interest in lowering their costs for children who use urgent care services such as EDs and hospitals.
Okay. Yeah, right over here.
On the evaluation of the air cleaner, are you able to look at the lasting benefit based on the behavioral change of the parent who presumably has to turn it on and use it? Can you distinguish between well-used air cleaners and ones that are not being used? And secondly, is it strong enough evidence of its effectiveness to entrust the insurance companies?
So a couple things. I mean, in Peyton Eggleston's study, the air cleaners, 50% of the air cleaners were on 50% of the time. So it actually was not anywhere near close to 100% of the time. And so those figures I showed you, though, aren't selected for the people who used it more or used it at all. So that's despite non-adherence, if you will. So I don't know. That was an intention to treat design, and I don't think he broke it out by looking at people who did or didn't use it very well. But it allowed for some non-adherence. You could wonder if people who adhere to something do other things better as well, and so I think that's a fair point. But I don't know how to address that from that trial. In terms of whether people should be incented to pay for these things, I think that's an important issue. If we look at things, if we think there's a carcinogen in the drinking water, I know a lot of people get together and they yell about it and argue about whether to take it out, but we don't insist that there be a randomized controlled trial that shows that if you take it out of the drinking water, that a community doesn't get cancer. We just say it's a carcinogen, it's in there, and if we know a way to get it out, we should do it. I think there's an abundance of evidence that particulate matter and nitrogen dioxide, as just two examples of pollutants, harm people with respiratory disease. And so, I don't think we necessarily need to insist on the same level of evidence that we do to bring a drug to market to say that, something that's logical, that does in fact reduce the pollutant that we know is harmful, ought to be used. And so I think we're at a point where we have enough evidence to say, gee, these things aren't that expensive. They cost hundreds of dollars. They don't have a lot in terms of maintenance. They use electricity at the rate of about a 60-watt bulb. And so we're not talking about something that's over the top expensive that actually doesn't wear out very fast either, and that there is clinical trials evidence of efficacy in both reducing pollutants and improving symptoms. So I think we're at the point where people should want to do this and spend several $100s, which might be 2 months worth of medication equivalent, on one more thing that doesn't harm people either.
I have a question. How do we decide an optimal number of visits, and do you think that more visits mean more better results or the opposite? That could affect the cost effectiveness of the intervention.
Yes, so we actually want to look at that because we know that a 6-home visiting model is expensive, it's time consuming, you need a lot of admin support to continue to follow up with families. And part of our Medicaid claims data analysis is actually going to look at where did we get the biggest bang for the buck? And so, was it at 4 visits when we really saw adherence kick in and ED visits and hospitalizations drop? I have a feeling it's going to be somewhere between 3 and 4. And I know that other asthma home visiting programs have not always using a 6-home visiting model anymore. They've dropped that number somewhere between 4 and 5, depending on the program. So I expect that we'll change somewhat. We'll learn from the data.
Okay, we do have a couple more comments and questions online. One is whether the Baltimore City Sanitation Department plays a role in cleaning up communities to minimize rodents, if they've been involved at all.
So we didn't coordinate services directly with DPW, but there are services in the city that are related to trash removal and rat rub out. So, but we didn't directly coordinate with them.
Okay. And this is a comment from an asthma and allergy sinus center. The cost savings are impressive. I just want to comment that I'm confident that longitudinally the cost savings would be even greater as the families become more comfortable with the use of daily controller medications, develop greater trust and bonds with their healthcare providers, and ultimately more appropriate utilization of healthcare resources, seeing PCP/specialists in outpatient setting versus ED visits. I find that often it is trust in the system and personal comfort with their understanding of asthma, in addition to better symptom recognition, that leads to better medication compliance and use of daily controller meds. Education is key. So, did we have another question in the back?
Kind of a larger contextual issue. I know you're working in a specific and very important field. What I'm concerned about is that we have, particularly among the socioeconomically deprived communities, other epidemics of diabetes and obesity. And I'm wondering if there's anybody in public health or related fields who's taking a look at whether or not there's any connection between what you're doing and these other epidemics which are plaguing these communities at a great human cost and social costs.
Yeah, it's a great question. Our current center, the third iteration of our Center for Childhood Asthma in the Urban Environment, is actually funded to look at dietary issues as the role that they play in developing allergy and asthma. And it's for reasons that you say. There's a concordance of epidemics in populations of people like we're studying, so like African Americans in the inner city, that diabetes is higher, obesity is higher, and the time trends are very temptingly overlapping, so that the obesity epidemic took off at about the same point when the asthma epidemic took off, and where there's a change in the inflection point of the epidemic curves. And what we're looking at least in our center, is how the composition of diet has changed over time, and how that composition may both provoke allergy and asthma and also fail to protect against it. So with the general notion that there's a pro-inflammatory component to diet, with things especially like processed meats and foods of that sort, and a lack of antioxidant capacity through less fruit and vegetable, less fatty fish and things of that sort. So we're taking both an observational and an experimental approach to looking to see if we can change the trajectory of asthma and allergy with things like diet. I think they're all intertwined, and I think that they're hard to separate, but it's really where there's a lot of value. It's not just one factor.
Okay.
I'd just like to comment on that, because I think what Kate was saying before about also offering other resources to families is a way that you can also combat some of the other problems by going in with not just we're just going to fix one problem, but like going into the house and try to provide as many services as possible through an integrated delivery of services.
Okay. I think we have time for one more question, if we have one. Or maybe not. I think that wraps up our presentation for today. So I really want to thank again Ms. Scott and Dr. Diet for coming today for this great presentation, and thank you all for coming. And we hope to see you again next month on the third Wednesday for our next Grand Rounds. Okay, thank you very much.